This is the Birth, Baby, and Life podcast with Kristen Burgess, and we're talking about breech babies in episode number 202. Hey mama, in today's episode, we are going to talk about some myths versus some realities with breech babies, and I'm also going to talk some about what physiologic breech birth looks like because it looks different than birth with a head down baby, and I don't feel like we talk about this enough. So I am Kristen. If you don't know me, I am a pregnancy coach and I work with mamas all over the world. I love pregnancy, birth, and babies, and I especially love helping mamas to have an enjoyable pregnancy, grow a healthy baby, and give their babies a beautiful birth experience. I also work one-on-one with moms to help them create a healthy and happy home, and I've been doing this a long time, and I just got done with a breech workshop, and I've got to say that it doesn't matter how many years I've been doing this, I still really love working with pregnancy, birth, and learning new things. So I'm excited to share some of what I've learned in the workshop with you today because I don't think that I've really talked about breech babies enough. So I'm very glad to have the opportunity to do that. Now, the workshop that I took was the Breech Without Borders workshop, and I took the workshop in 2024. If you're listening to this in the future, there has been a lot of change and learning that has gone into understanding physiologic breech birth, and I am imagining that that research will continue to be done as more and more breech babies are able to be born vaginally. So if you're listening to this several years in the future, please check and see if I've done an updated podcast since that time, because some of the learning that we've had might have changed, because this is one of those areas where a lot of research is being done and a lot of things are changing quickly. So that's just a quick caveat. Now, like I said, I did the Breech Without Borders workshop. So I had Christine and her team, Rixa. I'm going to show you guys, I'll hold them up. If you are listening to the podcast, you may want to go to the show notes and click to watch at least through the portion of the podcast where I'm showing some statistics. I'll see if I can put screens on the show notes. I'm not sure because they are Rixa Frieza's slides, so I'm going to show them, but I'm not sure if she wants them to be there, but I'll give credit to her so that you'll know, and also link to where you can perhaps get some more information from them. I'm just going to show a few of them because sometimes a picture is worth 1,000 words, especially when we're looking at graphs, and we're going to look at that when we talk some about breech safety in a few minutes. So definitely check out the show notes or watch this podcast on YouTube, even if you normally listen to it on your podcast player. So let's start. I said we were going to talk about some myths and realities about breech birth, and I wanted to start off with something that is probably something that I have said before in the past, and after attending this workshop I've realized is not true, and that is the statement that breech is a variation of normal. Now, I've said this in the past, and you hear this a lot, because it is true that 3 to 4% of babies are in the breech position at term when it is time for them to be born. But when we look at the dictionary definition of normal, normal means standard or expected. And that is not a standard or expected position for a baby to be born in. In fact, the standard or expected position for a baby to be born in is to be head down, which is called vertex or a cephalic presentation. And that position is normal. Baby to be head down, usually with their back slightly turned to the mother's left and with a well flexed, which means a tucked in head. So that position and that position only would be considered the normal position. And any other variations of that, even if you have a variation with a head down baby, for example, a baby who is posterior, which means that the baby's back is to your back, those would also be considered variations and not necessarily quote unquote normal. So I love what Christine, who I worked with the most during the breech workshop, I loved what she said, which is that breech birth is not quote unquote normal, but we should normalize vaginal breech birth. So even though breech birth is a variation or a change, a shift from normal, it is something that's not normal, we should normalize letting these babies be born vaginally, or at least giving moms a chance at a vaginal birth. And depending on where you are in the world, most of the world is pretty negative towards vaginal breech birth these days. So if you are at term with a vaginal breech baby, there is a good chance that you will be told that you will automatically be scheduled for a cesarean section. And as we'll talk about, cesarean section is not a risk-free choice. And it has great implications for future babies. So that's why you should understand what the statistics say about breech birth and why it's important, as Christine said, to normalize vaginal breech birth. And what we do want is we do want skilled providers, because as we get into the safety section, you'll see that provider's skill level is important, because the reality is that most of the time breech birth goes pretty normally, just like most of the time head down birth or cephalic birth goes pretty normally. But sometimes there will be, babies will have difficulties navigating down through the birth canal. I think one of the biggest misconceptions, and I talk about this a lot in Mama Baby Birthing, one of the biggest misconceptions that we have is that labor is about cranking open to 10 centimeters and then pushing the baby out. And that is a gross oversimplification of what happens with your body and your uterus. But it also kind of, it completely negates that the baby is an active participant in birth. Yet babies are very active participants in birth and in navigating down through the birth canal. And sometimes some babies need a little bit of help navigating out. And that's more likely to happen. It's more likely that a breech baby will need a little bit of help negotiating their way out through the pelvis and into the world. So those are just some realities about breech birth and some things to consider. So we do want skilled breech providers, because skilled breech providers will mean many more breech babies are able to be born vaginally and many more moms are spared from a cesarean that was probably unnecessary. We can and do understand a lot more about physiologic breech birth. So breech birth can be physiologic. I actually had somebody get into an argument with me online a few weeks ago about how physiologic birth was just a term that like midwives try and use to guilt women. And I bowed out of the argument, but it was like, no, physiologic birth is a thing. Like you can even go read an obstetrics textbook and they tell you about the quote unquote mechanisms of labor or the cardinal movements of labor. And that's like a nod to that labor has a physiology. So physiologic birth is when we kind of get out of the way and we let birth happen the way that it's designed to, which means that we let your body do what it's supposed to do and we let the baby do what he or she is supposed to do. So breech birth, just like head down birth, can be physiologic. There are quote unquote cardinal movements or mechanisms and movements that babies usually take as they work and rotate their way down to be born in the breech position, just as there are when babies work to be born in the cephalic position. Now, And when you do things and change things, just like for a baby that is head down, when we do things like leave the mom on her back all the time and restrict movement and poke at her and prod at her and mess with things and that can mess with and interrupt the course of her labor. The same thing is true for breech babies. Physiologic breech birth is different than with a heads down baby, and I'm going to come back and talk about some tips for helping have a physiologic breech birth at the end of the podcast after I talk some about safety. And like I said, for an example is that pushing can be quite a bit different with a breech baby than it is with a head down baby. And like I said, I'll circle back to that. But first, I want to start by talking about safety, because safety, I think, is really the biggest issue that comes to mind, because there's this belief that vaginal breech birth is really dangerous. And like I said, I've got some slides that I'm going to share with you, because I feel like a picture is worth 1,000 words. And these are slides that Rixa has prepared, Rixa Freeze, and they do a really good job of illustrating things. But we can't really start talking about the safety of breech birth without talking about the term breech trial, which was a study that was done in the early 2000s era, and it had a terrible outcome for vaginal breech babies versus babies who were a planned cesarean. So we had two moms who each one was carrying a breech baby at term, which is the end of pregnancy, and the ones who had vaginal breeches versus the ones who planned and had a cesarean for their breech baby, the outcomes were widely different, and they were very negative or very bad for the vaginal breech birth. We saw a composite 5% morbidity and mortality. So mortality is death, and morbidity is, there can be different ranges of it. There can be moderate or mild morbidity, which we'll talk a little bit more about this in a minute. And then there's severe morbidity, which is ongoing bad effects. So if we think about birth injuries or something like that, neurodevelopmental problems and that kind of thing. So that would be morbidity, is like basically injury or neurological damage, that kind of thing. So when we look at the term breech trial, the composite of that morbidity and mortality was 5% for the babies who were born vaginally versus 1.6% for the babies who were born by C-section. And that is a really big difference. Like, there was a lot more morbidity and mortality in that study for vaginal breeches. And it literally changed breech practice overnight. Now, prior to this, I think there was some reticence to do vaginal breeches, but at this point, even most places, it's not true everywhere, which I'll point out later, but most places that offered vaginal breech birth just stopped overnight when this study came out. And that was, that was a really big deal, because all of a sudden, all of these women, remember 3 to 4% of women are going to have a breech baby at term, and all of a sudden they're all having C-sections overnight as a result of the term breech trial. So the term breech trial, following that study, has received quite a bit of criticism, and as we'll talk about, there are other studies that have made really different conclusions. But I wanted to share with you some of the criticisms of the term breech trial, because it's considered like a cornerstone piece of evidence. And if you're talking with a doctor about breech birth, or even a midwife about breech birth, and they bring up the term breech trial, these might be some points that you want to discuss with them or bring up and ask them if they've considered or if they've looked at the literature that is critical of that trial. So this is from Rixa Fries's data. And she says that one of the critiques is the randomization was in labor. So it was technically a randomized trial, but the woman was randomized in labor. And so, if you think about labor, it can be really hard, because it's hard to find women who don't have a preference about their birth. And so to really randomize in labor is difficult. And what can we extrapolate from that or that data? Because, you technically, I guess, had women who didn't care if they had a cesarean or if they had a vaginal birth. And so how does that impact the way that a woman is in labor and that kind of thing? So that's one criticism. A big criticism is that twins and head down or cephalic babies were accidentally included in the criteria. And this is really significant, not because those births went by without a hitch, but because those births ended up being complications and counted in the statistics against breech births, even though this was supposed to be looking at singleton term breech babies. So a singleton is one baby. Some countries had high rates of non-participation. So some of these, like Scandinavian countries, where breech was maybe more of a normal practice and home birth and midwifery care was normal, they didn't have women who agreed to be randomized in labor. And that, again, that goes back to the whole thing of randomizing in labor, is you have a lot of women who are like, nope, I won't participate, because they don't want to be randomized into having a cesarean or, having a vaginal birth, I guess, if they wanted to have a planned cesarean. So that kind of goes back to that point of women don't want to be randomized in labor, so you have trouble finding participants. In some countries where perhaps there were more skilled breech providers or more of a legacy of doing breech births, women just didn't really choose to participate at all. 20% of the vaginal breech births did not have a skilled attendant. So that means that the doctor or the midwife who was attending the birth didn't have special skills in breech. And we'll come back and talk about why that's really significant shortly. There was also inconsistent management, like there wasn't a set protocol for how they were going to manage things. And that, again, that kind of goes back to the lack of skills. There was also no measure to determine fetal head position, so they didn't really try and determine prior to labor if the baby had his or her head in a good position. Because actually, just like in cephalic birth, where you want the baby's head to be well flexed, which means tucked into their chest, you really want the same thing in a breech birth, because a hyperextended head can cause problems in birth. And there was no way that they were screening to see, because some providers would risk out a hyperextended head or would try and get baby to flex his or her head prior to labor and birth. So there wasn't any way that they were like looking at that like ultrasound or anything to risk that out. And some of the facilities didn't even have ultrasound available. And again, most of the perinatal deaths were actually not because of the breech position. So when we look at the fact that there was a high mortality rate, but most of those deaths weren't because of the breech position, then can we really count those fairly? So there were 2 sets of twins, like I mentioned. There were also 2 growth-restricted babies. So those babies had a condition in utero, in the womb. There was 1 baby who had some sort of congenital malformation. So the baby had birth defects that weren't really compatible with life. There was 1 baby that had spina bifida, which means a spinal cord is exposed in some way, and that ruptured during the birth process. And that probably would have happened regardless of what position that baby was in. And then there was 1 baby who was head down who was stillborn. So how did that baby get counted in the statistics? That doesn't make any sense. So those are some major critiques of the study itself and the data that they included and pooled, and also the lack of data because they weren't able to randomize as many women during labor as probably they would have liked. And then another critique is that there was a long-term follow-up to the study at 2 years. So when the babies were 2 years old, they followed up. And that follow-up, this kind of plays into that morbidity, which is what are the ongoing effects? Because one thing we do know, and I'll say this up front, is that when you have breech babies, there is greater short-term morbidity in those babies. So that could be things like low APGAR scores. They need a NICU stay. They may need more resuscitation to get going initially. So those things are true for breech babies. They tend to have a little bit higher level, and we'll come back and revisit that in a minute. But long-term morbidity, that doesn't seem to play out. And actually in the term breech trial, which showed all of this great difference between mortality and morbidity, it was the same. So in that one they say, this is a quote from the follow-up to the term breech trial. Planned cesarean delivery is not associated with a reduction in risk of death or neurodevelopmental delay in children at 2 years of age. So in other words, they found no long-term risks to vaginal breech birth. And that was even in this really overall harsh study about breech birth. And then other large trials have had really, really different results. So this is one of the things that I wanted to show you on the slide. So one big study was the pre-MODA study, and I will link to information where you can go through some of Rick's presentations and stuff and read about all of this and what all the acronyms mean and everything. But pre-MODA was a study that came out about 6 years after the term breech trial, and it just had very, very different outcomes shown. And pre-MODA was a study that was done in countries where there were many skilled providers for their breech births. So I'm going to show you this. Again, this is Rick's slide. And if you look, here's the term breech trial up here. And then down here, here's the pre-MODA. So the green is mortality for planned vaginal birth. So you can see that it was 1.3 for the term breech trial, but 0.8 in the pre-MODA study. And then mortality for planned C-section is in the kind of orangey red color here. So it's 3 in the term breech trial, and I'm assuming it's right around 0.8 in the pre-MODA because it's in the same area. So essentially in the pre-MODA study, there was no difference between mortality for vaginal breech birth and cesarean. And then the purple is morbidity, and you can see it's quite high for the term breech trial, though as we've talked about, this was probably short-term morbidity. And it's 1.5% in pre-MODA, so it's there, but it's not nearly as high as 3.8% up here. And then morbidity for planned C-section was much lower in the term breech trial with 1.4%, but it's 1.39% in the pre-MODA study. And so it's really very close as well here. What do you need, guys? Okay, he'll have to wait till after the podcast. Okay, sorry about that, guys. I am a mom here. So again, that's a pretty stark difference in studies, and there was a number of studies that showed that. And then another thing that I think is important to consider, and Rixa had a slide about this too, is the consideration that the term breech trial or pre-MODA, they were comparing planned vaginal breaches to planned cesarean births. And there was a question of, should that be the only point of comparison? Because perhaps we should also compare planned vaginal breech births to planned cephalic breech births, because The reality is that if you were to C-section every mom at 39 weeks, you would have overall less neonatal mortality and morbidity. Now, maternal mortality and morbidity is a different story, and I'm going to come back to that. But so in some ways, when you're comparing C-section to vaginal birth, you're comparing apples to oranges. So some researchers have said that we should compare apples to apples. So we should compare planned vaginal breech births to planned cephalic or head down breech births. And so this slide actually takes a look at that. So you can see up here the term breech trial and then premoto, which I just showed you large on the other slide. And then these are a few other breech studies or breech composites. Like this is RCOG's data, which is the Royal College of Obstetricians and Gynecologists in the UK. So this is kind of their aggregate data. And then I think the SOCG, I think, is the Society of Obstetricians and Gynecologists in Canada. But anyways, you can see that RCOG chose to also include planned cephalic births down here. So what we see is we're looking at planned vaginal breech births, planned C-section, and planned cephalic of neonatal mortality. Again, so we're looking at that. And so if you look, you can see that the head down babies also had a 1% rate. So C-section is lower because the orangey red ones are C-section at 0.5, 0.5, 0.5, 0 to 0.8. C-section is lower, though again in the term breech trial it was higher. But in these studies, which are a little bit newer and perhaps more fair and accurate studies, the planned C-section rate was lower than everything, but the planned vaginal breech is not necessarily that much higher than cephalic birth, though there is a little bit more risk to a planned breech birth. So when we look at that, we look at the fact that we need to both compare apples to apples, and I think it's valuable, everybody thinks it's valuable to compare the C-section for breech to the vaginal breech birth, but also we should look at what is the rate for cephalic, vaginal cephalic birth. Sorry, alphabet soup here. Okay, so another thing that we should look at and consider when we're considering the safety of breech birth, and especially the safety of a vaginal breech birth versus having a planned C-section, is looking at the numbers needed to treat. So number needed to treat is the number of C-sections that we need to do in order to save one baby's life. And it's important to look at that, and it's especially important to look at that in different studies because we get vastly different results. So here's another slide that RICSA produced. And here we see this square. The term breech trial said that you need to do 104 C-sections to save one baby. So for every 104 C-sections you do, you're going to save one baby. And then we have other studies here. So each of these colored blocks is a different study. And as you can see, they're all quite different. Even getting up here, this is the RCOG guidelines, so that was that aggregate from the UK. They said you needed to do 666 C-sections to save one baby. And then if we look at premoda up here, which is actually the white, we say that you needed to do, there is no number needed to treat. Like, you could do infinite C-sections and it wouldn't benefit baby mortality at all. So that's really something to think about. Okay, let's return and talk for a minute about this concept of morbidity. And like I talked about, there is a difference between short-term versus severe neonatal morbidity. So neonatal morbidity means problems for the baby. Most studies do show, like I said, that there is some increase in short-term neonatal morbidity for babies who are born vaginal breech. And so that, again, could be a low APGAR, a NICU stay. They may need some ventilation breaths to get going. They may have some birth trauma, like breech babies can have some bruising on their bum and stuff that can look pretty gnarly in the first couple of days. But just like some vertex babies will have a cone head, or they'll have like a bruising and stuff on their head, and that starts to resolve pretty quickly. The same is true for most breech babies. So those things would all be considered short-term morbidity. And most studies do show that there is some, though basically all studies show that there is less than was shown in the term breech trial. And some studies show that there could be greater severe morbidity, but except for the term breech trial, it's not statistically significant. So I'm going to show you another slide here to illustrate that. So we can see here the orange is the planned C-section, again, like this reddish orange. And then the planned vaginal birth is the green. So here you can see the term breech trial is at the top. And you can see that their orange and their green are quite different. So C-section versus the planned vaginal. And so this is a statistically significant difference. But all of the others here, it is not statistically significant. So all of the ones that are in red show that that difference is not significant. So that means that the difference is so small by the decimal point that it's not considered statistically significant in the literature. So it could even be chance, but it is important to acknowledge that there is some slight difference in short-term versus long-term neonatal mortality, but it doesn't really seem that there are any long-term neonatal, not mortality, morbidity effects, which means like injury to the baby that would be ongoing. So that's an important distinction to make. And it's also important for you to understand as a mom, or you to understand as parents when you're making this decision, is there is a chance that short term, again, baby may need a little bit more help to get out. Baby may need ventilation breaths. There is more chance of low APGAR scores. In fact, an initial low APGAR is pretty normal. And so thinking these things through, talking them through with your midwife or with your doctor as you're considering a vaginal breech birth is an important thing to do. And so it's really, I think it's important to look at absolute risk. Relative risk is when they say things like, oh, if you have a planned C-section, then your baby is 4 times less likely to die. And that, that is relative risk, and it doesn't communicate very well. So the absolute risk that we see, and I think these statistics are from ARCOG in that 2017 report, is the absolute risk of mortality or morbidity for baby in a vaginal breech birth is 1 in 500. For a vaginal cephalic birth, it's 1 in 1,000. And for a planned C-section for any baby, it's 1 in 2,000. So those numbers are from ARCOG. So as you can see, there is an increased risk, but it's still a lower risk. Like there's a 499 babies that are not going to have that effect. And then there are some countries like France or Belgium, for example, they never stopped teaching vaginal breech to their obstetric providers or their midwives, and they actually have much lower levels of absolute risk. In fact, finding really no difference between vaginal breech birth and planned C-section. So that's an important thing to remember too. Like I said before, we'll come back to this fact that having skilled care providers does seem to make a difference. The only real consensus, because again, the studies in different countries and that sort of thing show differences, the only consensus is that breech babies do generally have lower initial APGAR scores, especially in that first minute. So that's something to consider. That would be a big thing to consider, is that first APGAR is probably going to be lower. And you also know that having a skilled birth provider does seem to make a big difference. And so that would be something you want to consider. Another thing to consider is kind of flipping this around. Instead of looking and scrutinizing breeches, is looking at the fact that a C-section isn't risk-free. Because this is something in our society that is definitely a widely held belief, is that a C-section is risk-free, that it's just another way to have a baby, and that it's basically the equivalent to a vaginal birth. And I think part of it is because some women don't care how they give birth really and legitimately, and I'm fine with those women. But some women really do, and they feel like having a C-section is not how they wanted to give birth. It impacts them and how they feel about themselves as a woman, perhaps, but often it's feeling like a lack of control, a lack of autonomy, a lack of respect, having something done to you, being treated poorly when you were in birth, in labor. And all of that ends up tying to a cesarean section, being bullied. And so I think, I don't like using the word gaslight lightly. I'm going to end up using it in the next podcast too. But, in some ways, I think it's a societal gaslighting of women because they have legitimate concerns, but society isn't to the place where we want to make that change in obstetrics. And also, I think it's a way for women who have experienced these feelings and want to sometimes just cover them up or not acknowledge them or pay attention to them at all. And they'll gaslight other women and talk about, a C-section is just, you have a healthy baby and that's all that matters. That is literally the standard line in our culture. And I think, I don't think that we should treat it that lightly. There are some moms for whom it is that light, and that's fine. But there are a lot of women who deserve to have support as they process their birth experience, and all women deserve to feel respected. But anyways, I don't want to get off on too much of a rabbit trail. So C-section but it's not just an equivalent, and it's not a risk-free option. And in fact, while I said that a C-section at 39 weeks is going to end up with babies who are better off in most conditions, and when I say that, it's like a marginal thing. It's not like a huge thing. We shouldn't start C-sectioning every mom at 39 weeks. But we know statistically that we would have a little bit less neonatal mortality and morbidity if we did. But the picture for moms is a very, very, very different story. And that's one of the reasons why this is such a complex discussion, because C-sections are not risk-free. And also I want to say that even though I just said the thing about mortality and morbidity for babies, we actually know that C-sections aren't risk-free for babies, because babies are more likely to have childhood asthma. They're more likely to have type 1 diabetes, autoimmune diseases, like altered stem cell is something that we're researching. There seems to be altered stem cell responses and epigenetics going on for C-section babies. And also, as most of us know at this point, they have an altered gut microbiome. So those are really big, significant things that we need to talk about as well. But especially we need to look at the impact of maternal health, because I feel like, and I'm going to come back and talk about this a lot more in the next episode, because I'm going to talk about the erasure of women. But I feel like there's this low priority on maternal health and women's health in general, and there has been historically, and where I felt like we were changing that, I'm worried a little bit that we're backsliding now. But we don't talk about the moms enough, or we just dismiss the moms and pretend like, again, that it's all equivalent when it's not. So the reality is that moms do worse after C-sections, and especially for women who are going to have another baby, they're much more at risk for something called SAM, SAMM, which is severe acute maternal morbidity. And so a woman who deals with SAM is 6.9% of women, or 6.9% more likely after an elective C-section, or 6.9% versus 3.9% after a vaginal birth. And this increased risk is not just in the pregnancy where the C-section happened. This risk persists into the next pregnancy and the next pregnancy and the next pregnancy. Now, some outcomes seem to be similar. They don't seem to be as affected by how the birth happens, like breastfeeding, caring for the child, the mom's sexuality. Those things don't seem to be impacted as much. Also, fertility doesn't really seem to be impacted as much. But other outcomes are affected by having a C-section. So planned C-section leads to higher C-sections in subsequent pregnancies, and also fewer children overall. And we think that that is not because of fertility problems, because like I said, it doesn't seem to affect fertility, but it seems to be because women are less likely to want to go through another C-section. And the children that they do have are spaced further apart than when women have vaginal births. So it affects a woman overall. And as I talked about a few podcast episodes ago, when we look at women, many women will tell you that ultimately they ended up having fewer children than they wanted to. That seems to be a thing. And there's a big societal thing going on overall there. But when we look at the fact that women are already probably having fewer children than they wanted to have, and a C-section is going to make that even lower, that's really something to think about and to consider as a side effect. So there's also greater risk in future pregnancies. So for the C-section mom, many of the risks are dealing with future pregnancies and future babies. There's a greater risk of uterine rupture, a greater risk of placenta accretia. The rate of placenta accretia, which is the placenta kind of invading into the uterine lining more than it should, is much greater after a C-section pregnancy. And the prevalence of this, the amount that we see this happening in society, is much greater now because our C-section rate is much greater, and the placenta will kind of invade through that C-section scarring. So for every baby saved, there are problems. So I've got a couple more slides because, again, in this case, a picture is truly worth 1,000 words. So this is another slide from Rixa, and she's showing just how complex the risk calculus is. So this is coming from a study in 2005, and it looked at cesareans for breech babies. So 8,500 cesareans for breech babies. And we see here that 19 babies were saved, in theory, by the C-section. But the cost was 4 avoidable maternal deaths. So for every 19 babies saved, We lost 4 mothers. And for every 19 babies saved, there were 9 fetal deaths and future pregnancies due to the uterine scar. And there were 10 potentially life-threatening maternal complications in future pregnancies. So in future pregnancy, or we saved 19 babies, but we lost 4 moms and 9 babies, and then 10 moms had life-threatening complications in future cesareans. So that's why it's kind of a balance and why it's labeled as complex risk, because it's really not straightforward. It's quite complex. And then here's another slide that communicates that. In the Netherlands, for every 3 to 7 babies saved by a planned C-section, 1 mother died. So the odds of a mother dying after a planned C-section were 1 in 2,130. And the odds of baby dying after a planned C-section was up to 1 in 1,666. So again, it's not risk-free. You see this complex is a good word to use, this real complex need to consider, I'm not even sure how to say it, but this complex thought experiment that you even need to do to consider these things. So here we're looking at another slide which is comparing 1,000 planned C-sections to 10,000 planned C-sections to 10,000 VBACs. So for the planned C-section, we're going to save 26 babies for a breech C-section, but we're going to have 4 to 5 maternal deaths. And then we're going to have 27 babies lost for this VBAC. So we've got 25 severe acute maternal morbidities and 4 peripartum hysterectomies, which means that she can't have babies anymore. And then 153 postpartum hemorrhages, 17 uterine ruptures, 4 placental abruptions, invasive placenta, and placenta previa. So what we're seeing is that we saved 26 babies with the initial C-section, though we had some maternal morbidities and some hysterectomies. And then when this mom goes on to have a VBAC following that, we're going to lose 27 babies plus have all these complications that are caused because she had the VBAC, plus 4 to 5 maternal deaths. So ultimately, we don't save any babies. As Rixa describes it in her presentations, when you have a planned C-section for a breech baby, you're essentially just pushing the risk down the river. You're pushing it down the line. You can't get rid of the risk. You just shuffle that risk to a future pregnancy. And if the mom doesn't have a future pregnancy, okay, well, the risk may have stopped there. But many women want to have another baby, and so that risk gets shuffled down the line to that future pregnancy. And I think that, and then this one is repeat C-sections. So this one is the same thing. You had the initial moms who had the 10,000 C-sections. And then with repeat C-sections, we have probably more maternal deaths. And then we lose 14 babies. And then we have the same kind of morbidities and those sorts of things. So ultimately, if you have C-sections followed by planned C-sections, you net save 12 babies. But you've ended up with a lot of babies lost as well. So it's really complex and something that's heavy to consider, but I think that if you are choosing the way that you want your baby to be born, it's really important to consider it. And it's also important to consider that having that primary C-section, that first C-section, really does impact the rest of your years of having babies, and considering how that might be affected and looking at that when you consider the pros and cons of a planned C-section versus having a vaginal breech birth, and having a vaginal breech birth with a skilled provider versus with a provider who's not skilled, or even a free birth or that sort of thing. You really need to look at everything. And these risks are really also very magnified in the developing world, and that may not pertain to many of you who are listening to this podcast, but I think that it's important to say that in a developing world where safe C-section or immediate C-section isn't as available, these risks are, the risks are magnified. It's much more likely that you're going to lose mothers and babies, both during the initial surgery and certainly subsequently. Okay, so some people will ask, what about home birth? And I feel like it's important to discuss this because out-of-hospital births do show more risk than in-hospital births. Now, part of this is because we don't have the kind of study levels that we have, and there's a lot that we don't know about the statistics that we do have. For example, we don't know a lot about provider skill level. We don't know how many of the babies were surprise breeches versus known breeches. We don't know about the type of breech baby. We don't know about maternal position during the birthing. And we also know that there are a large cohort of midwives who are very skilled in breech birth who do not submit their statistics. So a lot of the statistics for out-of-hospital birth are from MANA, which is the Midwives Association of North America, which is a voluntary statistic organization. Home birth midwives and birth center midwives can send their statistics in voluntarily. And many women do, but there are some of the most skilled providers who have been doing breech births for a long time who do not submit, because some of them just don't submit to MANA in a general rule. It's not just that they hold their breech ones back. So we have much smaller studies and sample sets, but it does, and it probably plays into the fact that do we have providers who are really skilled in breech or not? But it is important to know that out-of-hospital breech births do show a little bit higher mortality and morbidity than those in hospital. Some quick notes to think about as we talk about breech, and then we're going to talk about physiologic breech birth, is if you were a breech baby, there does seem to be a genetic component. There's a much greater chance that your baby will be breech. So think about, how will you feel if your baby's breech? And I think this is a good question, a good thought experiment, or something to journal over for every mom, is how will I feel if my baby ends up breech? What will I do and how will I approach that? And this is a good time also to talk about versions, an external version. So the instructor that I worked with, Kristen, is a very experienced midwife. She's done many breeches. She works with Doctors Without Borders and does all kinds of pregnancies and births. You know, she just takes what comes to her kind of thing. And she says that she trusts that babies are breech for whatever reason they need to be. So she generally does not try to do versions because she is just going to attend the birth if it's a breech birth. And so that's something to think about. Sometimes we know that babies are breech because their cords are tangled in certain ways, or breech babies are more likely to have a neurological condition because babies with a neurological condition are more likely to be breech. So that's something to think about. So sometimes babies are breech for reasons other than just perhaps chance. And that's something that's important to consider, and especially to think about version. Now, can you try an external version? Sure. Can you try the Webster technique, spinning babies, all those things, and do all the things? Yes. Christine's kind of recommendation was that, okay, we're going to talk about this. We're going to go over everything. We're going to do all the things, and we're also going to talk about breech birth and that kind of thing until 36, 37 weeks. And then we're just going to say this baby is breech. Enjoy the rest of your pregnancy. We've done the rest of that preparation, and now we're just kind of holding these few weeks before the birthing time is sacred. And you're just like any other mom now. You know, you're preparing for your baby's birth. And I really liked that way of thinking about it. So let's touch on breech nomenclature for a minute, which is, you know, just what does the terminology mean? And I probably should have brought my little baby guy over here because he might be helpful. So I might grab him real quick. So we've got Ari here, and so he is a doll. He's not a real baby. He just looks real. And so when we talk about breech babies, so we're talking about babies coming bum down. So if you have a baby whose legs are up like this, that is a frank breech baby. So that is a position that used to be actually the position that providers didn't like, and now they seem to like it. So babies like this, and we want their little heads tucked, so we'd kind of be like this in the womb. Now, if you've got a baby who is like this in the womb, this is called a complete breech, so they could be sitting like this. And sometimes babies will be like half and half. Let me see if I can even get Ari to do this and hold him. So he's got one leg up here and one leg like this. So this is an incomplete breech baby. And then there's another breech baby that's called a footling breech, and that would be that baby's legs are down. And the reality is you could have a footling breech baby who is premature, but a term baby just would not have room in the womb to be footling. So if you see pictures, and there's some pretty cool pictures online of like the feet coming out first, then that baby was probably a complete breech baby or an incomplete breech baby. And then as they're coming down, they drop a foot. And so I like what Breech Without Borders calls that a dropped foot baby. But that baby is actually a complete breech baby or an incomplete breech baby that's coming down. They're just a dropped foot breech. Now I think it's German, in the German textbooks, like they have like 9 different breech classifications, but I think that it's really helpful basically just to consider that there are 2 or maybe 3, because there's the frank breech, the complete breech, and then the incomplete breech. And then if you've got a baby who's coming and you see a little foot at the opening to the birth canal, that is probably a complete breech who dropped his or her feet. So we'll put Ari down and get my notes back. But so you know now the types of breeches, and both of those types of breeches, or all of those types of breeches, can be born safely vaginally. So let me see if my notes will load here. So I wanted to talk a little bit about physiologic breech birth, which I will, let me see if I can get back here with my notes. So a physiologic breech birth, the most important thing for you to remember is movement and listening to your body. So freedom of movement is really important in any birth, in a cephalic or breech birth, but I think that we see that, you may hear all kinds of things. Like another myth that you might hear is hands off the breech, and we'll talk about that in a minute. But you'll see like that providers put a woman into a position, but like hands and knees is a pretty common one to see. But what's really important is that you realize that you birth your baby the way that feels good to you and the way that you want to birth your baby, because you are the one who is responding to what's going on inside of you. Like I said at the beginning of the podcast, your baby is going to move a lot during the birthing time and work his or her way down. And your urges to move are often guided by what your baby needs. So one of the things the Pink Kit talks about, Wintergreen talks about in the Pink Kit, is that even the slightest bit of movement can go from where a baby's having a hard time getting down to, because like if you just let up the slightest amount of pressure on your finger, if you're holding your fingers tight and it's hard to move them, let up slightly, your fingers can slide over each other. So even the slightest change can help create room for your baby to move through, or for a breech baby to bring arms down and that kind of thing. I was actually looking at it because I've got this little breech guy here, and the little baby's kind of got an arm up, and so you would want to like help move and get that little baby to kind of pull that little arm down and come on out. So yeah, so movement is really key to a physiological birth of any baby, but especially remember it with a breech birth. There's like no prescribed position that you need to be in. If I was to say avoid any position, it would be on your back, though sometimes that might be helpful for a provider who's helping baby come out. But for the most part, you're going to want to be moving and upright in response to your own body. So yeah. Again, upright is often the safest, but move as your body says to move. And movement is really the physiologic position. There is no fixed position. Minimize talking, because talking is another intervention during your birthing time. So you don't need to be in your head, just like with a head down baby. You don't want to be in your head with lots of talking and stuff going around. You want to have that quiet atmosphere. You want to have things be calm so that you can focus on listening to yourself and listening to your baby and moving and doing what you need to do and get those hormones really going the way that they need to, just like in a head down birth. And then meconium might be normal in a breech birth, certainly as you're pushing and baby's coming down. If you've watched any breech births, you will see meconium coming because the baby's getting squeezed and the poop just comes out. But if your waters were to open and there were to be meconium, that might be normal for a breech baby, but it also may not be normal. So just like with a head down baby, you would want to check in and see how baby's doing if you have that. Another thing that may be different between a cephalic or head down birth and a breech birth is a cord prolapse. So if you have a frank breech baby and there's a cord prolapse, it's very much the same as with a vertex or head down baby. It is an emergency. But It's more common for babies who are complete breech. Remember, I had Ari sitting kind of Taylor sitting with his legs crossed. It's a little more common for those babies to have a cord prolapse, and it's not always an emergency because it's just roomier in there, and sometimes it'll fall down between baby's legs, but it doesn't get compressed. So that could be normal, and this is another place where a skilled provider can help you navigate, but it is a big difference between head down and breech birth, so it's something to be aware of and know about. And as I mentioned, breech babies, it's normal for them to have a lower APGAR, especially in that first moment. They may be a little bit stunned because breech is different. Babies want to be born head down, and a breech birth can be a little bit harder for a baby. So they can be stunned for a minute. But physiologically, what you want to happen is have baby come down, and then immediately baby is going to be passed underneath your legs or passed to you and up to you. Now, you may take a minute before you actually pick baby up, but baby being with you is absolutely the most important thing for a physiologic breech birth. In fact, even if baby needed some breaths, that resuscitation, those breaths should be done with baby right there with you, cord still attached, all that sort of thing. So even though it can be normal for baby to have a little bit of that stunned feeling right away, the baby should still be with you. And then I'm just trying to make sure that I get to my notes because my iPad here is about to die. So sometimes moms want to know about water birth, and many providers are comfortable with breeches in water. The mechanisms are the same. You can also assist with a baby being born underwater. Some providers prefer moms to be underwater. Some do not because they feel more confident that if they needed to go in and help baby that they're more comfortable with it being on land. So at the end of the day, I think it's really up to you because the verdict's still out on water birth, but it doesn't seem to increase risk for breeches. So that would be something to think about. Or you might talk about laboring in the water and getting out for actual birthing. But I think it's up to you, and it's up to you to think about what you want to do with that. And do you want to do that with water birth? Now, one thing that can be quite different with vaginal breeches is the pushing stage. So I'm really a fan of moms doing mother-directed pushing if they've got a head-down baby. So that means that you are not pushing until you feel that fetal ejection reflex, which is the involuntary pushing. The uterus is pushing down, like you could even not push, and it would still push the baby out. And not doing the counted pushing that they do in the hospital, but instead only pushing when you feel ready to. So that's physiologic mother-directed pushing, and it works really well for a baby who is head down, a cephalic baby. But it is different with a breech baby, and with a head down baby, you would wait for each contraction to push with the contraction and not necessarily push between contractions. With a breech baby, it may be very different. And the reason why, let me grab Ari again, is because when you've got a breech baby, once the breech baby's body is born, so if you can imagine a head down baby, and imagine that my arm is the uterus. So when the baby is being born, the uterus is right behind the baby's body. Okay? And so the head is born, and there's still all the body up in here, and the uterus is there. But with a breech baby, instead, when the head is born, so here's the uterus up here, and the head is born, the body is all the way out, all the way down there. So the top of the uterus, which is the part that pushes, so remember, in pregnancy, your uterus is like this, and then during birth, during each contraction, it contracts, but it never fully retracts. It never fully opens. So what happens is the top of the uterus gets thick like this. We call that the fundus, and this thick fundus actually acts as a piston to push baby down. The uterus is the strongest muscle in the body. It is incredible, ladies. So as you can imagine, with a baby who is head down, that piston is, pushing on the baby with each contraction. But if your baby is bum down and head up, you left your piston behind up here. And so I love what Kristen said during our workshop. She's like, it's all vagina power from that point on, right? Once the baby's head is down. And it also means that you do not need to wait for a pushing contraction, because the baby, once the baby's body's born, baby wants to be born, and baby needs to come. So you may need to just really give it a good push and give it a good oomph and help the vagina do its amazing work and get baby coming on down. So that's a big big difference. Now, you are going to wait for the pushing urge initially. And like I talked about with that little dropped foot breech, even if you see a foot, or your birth team sees the foot unless they're showing it to you in a mirror, you don't necessarily have to push. You don't really have to start pushing until baby is actually coming out and you're kind of at the umbilicus and moving down. So that's the point at which we're kind of at the point like we're crowning. So rumping is what it's called with a breech baby. So when the breech baby's bum is born, that's rumping. And that would be the point at which we say, okay, we're going to want to really give all of our attention to pushing. So if it's just a little foot, you don't necessarily need to push. Your care provider or you would just monitor the foot. And little feet that are poking out for a while might get a little bit swollen, but that is that kind of birth stuff that will go away in a few days, just like a head down baby might have a little bit of swelling on their head. So, but that pushing, once baby has rumped, you want to keep pushing even if there's no contraction, because again, baby has left the fundus, that thickened piston part of the uterus, behind, and it's going to be a bit more of your efforts to push baby out. And again, you want to go ahead, once the body's born, you want to go ahead and get the head born. And then this comes back to where it might be good to have a skilled attendant with you, because like I said at the beginning of the podcast, it is more likely that a breech baby may need some assistance with maneuvers and coming down. And so this could be where a skilled attendant is helpful. And if you're planning a vaginal breech birth, I would definitely sit down with your attendant and ask them their skill level and ask them what training they've had. For example, in the Breech Without Borders workshop, we learned many different techniques, but we primarily learned and practiced with a toolkit of 6 different techniques. And so you would want to talk with your care provider about when they might use those. So a simple and basic one is called a shoulder press. I'll see if I can prop Ari on my knee to show you. And a shoulder press is that your midwife just takes her hand right here. So baby's head is in, baby's body is born, but baby's head is maybe having trouble coming down because the head is flexed up a little bit instead of down. And so the shoulder press is just pushing in on baby's chest, and it causes the head to come down, and boop, baby will just come right on out. So one of the nice things about breech birth is your midwife can really watch the condition of the baby and can also tell a lot about baby's flexion. You see more than you do with a head down birth and can help correct that. But I would definitely talk with your care provider about those maneuvers and think about them. I know some of you are planning an unassisted birth or a free birth, and a lot of times I watched a really cool video of like this mom, she was having an unassisted birth and she just kept moving and kept moving and kept moving because that's what her baby was telling her what she needed to do. And probably all of that movement of her pelvis helped baby pull his or her hands down and flex the head and get into a good position. So, and that's one of the reasons why I really emphasize physiologic breech birth is going to be a lot about your movement and your pelvic movement to help baby move and navigate down through. But also a skilled provider, as we saw in the statistics, a skilled provider does make a big difference. And your provider can talk to you about different maneuvers, because there's maneuvers like the shoulder press that are very simple, and there are also maneuvers that are a little bit more invasive that help them go in and really get baby. Like if baby's got arms that are up there, then they can help you get those arms down and that kind of thing. So these are all things to talk with a provider about and really understand. But having a skilled provider who knows those maneuvers can make a difference. For example, one of the home birth studies that we do have, it's very small, is with Dr. Stu, who is an obstetrician in the California area. I've done some interviews with him before, and he will attend vaginal breech births. And knowing those maneuvers and knowing when to use them and knowing when to sit on his hands is a good thing. And you'll see that with skilled midwives as well. So it's just looking at those things and knowing that those techniques are there, that from time to time they may need to be used, and understanding, are you comfortable with that? Are you comfortable with thinking that, okay, I'm going to have this and have a skilled provider there, and the provider may need to do some maneuvers, or am I more comfortable with a planned C-section? So all of it is really looking at the evidence, looking at it from a statistical perspective, and also checking in with yourself, understanding physiologic breech birth, understanding how you can facilitate that, how you can work with your baby, how you can prepare for that, how your care provider may have prepared and how you want her to have prepared. So these are all questions and considerations, and I know this has been a mammoth podcast episode, but I really wanted to give you a lot of good information, and we can dive into some of these things more on a future podcast episode as well. With that, I'm going to leave you next week. I'm going to be releasing an episode on 1010. It is a very special episode because it is a day that we are thinking about 1010XX and considering how important women are to our world and how much we still need to honor and consider them. So I will see you next week, and I hope that you have a blessed week.